All right, so point requirements. We have changed our point requirements from what they were in the past. Um, Over here, you can see the point requirements for 3 tiers of active status: bronze, silver, and gold. They're the same requirements in each of the categories except for the bonus points category. So basically what this means is that you can, I know I've said this many times, but you can basically dive deep into whatever interests you the most after you get those minimum point requirements. Any extra points you get, like if you get 10 volunteering points, those extra volunteering points are going to count towards the bonus category. So the benefits of the different tiers basically include like free admission to some of our bigger events. You get eligibility for the scholarships that we apply for Kaplan MCAT prep. Um, and there's just different material benefits, like you get free merch when you're silver and gold, things like that. Lastly, you can view your points on the member profile page, or you can view them on the master point sheet, which is in the member resources page, both on our website. Again, you have to pay dues, both local and national, before you can actually see your points on the sheet.
All right, and so as we're getting towards the middle of the semester, as you can tell, people are already racking up points, but if you're struggling to get points, maybe the events you want to go to are filling up quickly, there are tons of ways to achieve your point requirements and get that bronze, silver, gold status. So definitely check out the AMSA Easy Points doc. It's got tons of different ways. You can probably reach an active status just by doing these things if you haven't already. So there's a ton of different opportunities, and definitely continue to explore our website and all the different resources we provide you guys, because there's a lot to get through and we don't mention everything at the meetings, but we have a lot of things that we are able to offer y'all, and hopefully you guys can take advantage of it.
Okay, so we use Discord for organization, communication, and reminders, so please join or you'll make me really sad, like Chris over there. If you have any questions about legit anything, just make sure you reach out to me or one of the officers by Discord or by email. Also, just to reiterate, if you want to view your points and your member status, you can make a member profile page and look at the point sheet, or look at the point sheet that's on the website or in the Discord.
Sorry, y'all, my computer glitched out, so hopefully we're on the right screen. But as you can see, we are welcoming our new officer assistant. So if you guys want to unmute and introduce yourself, please do so, and welcome everyone. Round of applause for our new OAs.
Hey, so my name is Krishna Jani. I go by Chris. I'm one of the social officer assistants for this semester and next semester. I'm a junior biochemistry major. A fun fact about me is that I really do not have pictures of myself, so that one is one of the more recent ones. Another fun fact is that I have broken both my hands while horse riding. It led to a very interesting summer, and yeah, you can just imagine. It was pretty much that bad. Well, I'm looking forward to being one of the social chairs with you guys, and I think we have a lot of fun activities planned.
I'm your other social officer assistant. My name is Caitlin Richardson. I am majoring in biology, and my fun fact is that I've traveled to Africa, but the more interesting part of that is while I was there, I stepped on an acacia thorn, which is like 2-3 inches thick. Yeah, I went straight through my shoe, so that was fun. But yeah, I'm super excited to be working with AMSA officers and working with you guys and planning some events. So.
Hey guys, my name is Joyce. I am a freshman and I'm majoring in biochem. And a fun fact about me is that I've never tried Pepsi, and I'm just really excited to work with y'all this year.
Hi, my name is Sarah. I'm a freshman chemistry major, And a fun fact is that I really like dogs, but I've never had one. So when I was younger, I used to make my brothers be dogs.
Hi guys, I am your fundraising officer assistant. My name is Anna Yang and I am a neuroscience major. Fun fact, I like to learn about true crime in my free time, and I would definitely recommend watching Stephanie Sue if it interests you guys as well. I hope to meet a lot of you guys at future fundraising events.
Awesome. So yeah, again, thank you so much to everyone who applied. We had a great pool of applicants, and we look forward to hosting new events and hopefully providing more things for all of you general members. But in any case, we still have AMSA Teams open. So we've decided to extend the deadline to another week. So AMSA Teams, which is different from the officer assistant position, but similar in that you will be working directly with officers to host individual events or new programs. That's still open for AMSA X Health. So due to lack of interest, we're not doing Thrift this year. But yeah, if you're interested in hosting mental health programs or even advocacy on campus, all of that stuff, we are definitely looking for more members through AMSA Teams. So definitely check out that form and fill out those responses. Additionally, we have Whole Human Advocacy, which was formerly known as AMSA Advocacy. So they've decided to branch off and are becoming their own organization with their own projects, not affiliated with AMSA. So we do have a unique application with there, and that'll be provided at a later date. So if you decide to check back on these GM slides or on that application file that's linked here, and at the end of the slides, then you can definitely access that as well. Finally, the Kaplan Scholarships. This is something that we offer every semester. So they're actually going to be opening, they're already open now, and they're going to be due October 28th. So we'll definitely be talking more about this later on, but suffice to say, these Kaplan Scholarships give you a lot of value if you're looking to have a one-on-one or free or partially funded guided MCAT course. So I think that's something that a lot of people are interested in, and thankfully we're able to provide that to at least, or to 4 of our members. So definitely be on the lookout for more information about that.
Yeah, so FAMSA, if you guys haven't heard, is our mentorship group, our mentorship program rather, here in AMSA. And so those applications have been open, and groups are all sorted now. Those emails went out yesterday, so groups should be kind of forming. Just as a quick note, if you're still interested in FAMSA, definitely consider applying. That application will be open until GM4, which is October 21st. That's slightly amended from what it was before. So if you're interested, let me know if you have any questions. Definitely reach out and let me know. And yeah, that's basically a little bit about FAMSA. This next slide here is super boring, nothing important. But if you ever wanted to come back to these slides and you needed links for relevant FAMSA things, you can find those here, and they're also on the members page. So yeah, let me know if you have any questions about FAMSA, and I look forward to seeing all the fun stuff that you guys get to do this semester.
Okay, so sorry, just a lot of Discord noises. So quick reminder to take pictures at events and send them to me for some points. And then for member resources, I wanted to just highlight that registration is kind of sort of coming up. And so to help people prepare for it, you should all check out the forum where we have like professor reviews for a variety of classes, especially, you know, those main pre-med classes. Additionally, if you've taken a class at UT and you want to write a review, I would encourage you to do so. Make sure you fill out the reviews like in the format highlighted on the forum page. And like when you fill out your review, you have to you do have the option of making it anonymous. So just for the name, put anonymous, and then you can send a screenshot to my email or on Discord, and all that'll be the way like you can get your points for it. One post gives you half a bonus point with a max of 2 points. So if you fill out 4 reviews on the forum, then you get 2 points total, and so that goes towards your bonus points. Next. Okay, so just stay on this page. All right, so member of the month. I didn't really want to explain this just yet in the previous meetings because we kind of throw a lot of stuff at y'all at the beginning of the semester. But we as an organization started doing Member of the Month to highlight members in our organization who really go above and beyond with involvement. And so the way we choose the Member of the Month is by picking 3 members with the most amount of points for that month. And then we basically, all the officers vote on who exemplifies our principle or our values as an organization, has a really doesn't just show up to events, but really shows a great amount of engagement. So we kind of wanted to take a more holistic approach for this semester. And so to present our Member of the Month for September, can I get a drum roll? Okay. Jimmy Nichols. Okay, so Jimmy is our Member of the Month for September. He is a second-year biology major who is honestly just an awesome person to be around. So after the meeting today, I'll add a Discord emoji sticker of Jimmy that y'all can use to congratulate him. So thank you, Jimmy, for being so involved this semester. We really like being around you. Next. So event updates. I've gone over the slide in other meetings, but just to reiterate, make sure you keep signing up for events. Sign-up sheets are open 8:30 a.m. the week before the event, and make sure you read the event descriptions and the rules for signing up for events and fill out the entire row before you sign up. Yeah.
All right, that's me. Just a quick reminder, we talked about this last time, but go get your proactive community testing on campus if you are in Austin. It's free, it's quick, it's simple, and it helps you keep everyone else safe. All right, so here are just some of the socials coming up. Debate night 2 and kayaking are coming up later this week. And please stay tuned for the email reminders if you are signed up for that, or for those 2 events. And then finally, we have GameSA, and we'll be playing Fishbowl next Tuesday. It's basically a combination of charades, password, and I forgot the other game. But it's really fun. Hopefully you guys can come out and see our first test run of the event.
And yes, sir, we're still having camping this year. Our semester camping trip is still going to happen. I made a mistake. It's not Saturday, October 18th. It's October 17th. So the sign-up sheet for that is going to be opening on Saturday. So please sign up if you'd like to go. We're going to Emelong. I think that's, Emelong. And we reserved 2 campsites so we can have 2 groups of 10 people and make sure that everybody stays, about 6 feet apart so we can keep it safe. But Kevin and I still really wanted to have it, so this is the best way we're going to do it. So I said it's not really camping this year because we're not really staying overnight like usual. We're just going to be there from like about 5 to 11, and we have a ton of activities planned, so it's going to be super fun. We'll be providing dinner and snacks and everything, so don't worry about that. And yeah, definitely sign up for that if you guys want to come out.
Yeah, and we just want to emphasize that even though we are having these in-person events, especially at camping, we are still enforcing all of those same policies. So you need to have your campus pass or symptom pass register as negative. Ideally, you would also have a negative COVID proactive test, and we definitely will be enforcing that mask policy very strictly. So definitely read those rules and policies if you haven't already.
Hi, everyone. So I'll keep it brief. Some events coming up these next 2 weeks are the Pre-Med Timeline Workshop, International Pre-Med Program Workshop, and a CPR certification program that we're doing with UT Nursing, where you'll actually get CPR certified. So please come out to those if you're interested in learning about any of those things. And then other updates, again, Kaplan events, kudos to all of you who have been attending them. Keep on doing so. Medical Media Challenge, I just wanted to clarify that the checkpoints on the calendar are really just suggested like dates for you to be able to pace out your listening to the podcast that we're doing this semester. So by no means do you have to like submit anything on those days or like actually follow them. just a suggestion. And then if you saw my announcement just a couple days ago, our wonderful member Lana has made a really awesome program called Socially Distanced Shadowers, where you can go and listen to physicians on pretty much a weekly basis and learn about their practices. So definitely check out that announcement and follow the Instagram and newsletter attached if you are interested. And then again, I've been having more calls this week, just with all of you who may have just wanted to chat about anything and everything, specifically pre-med stuff with me. So I just wanted to shout that out again. If you do just want someone to talk to, please do not hesitate to reach out to me.
All right. So for volunteering, for our upcoming events, we have the Central Texas Food Bank, which is actually tomorrow. On the sign-up sheet, there are actually 4 or 5 spots left. So if you do have a car or you have a roommate who could drive you there, I think Central Texas Food Bank is like one of our like consistent and staple volunteering events, and it's a lot of fun. We usually go there a couple times a semester and we sort food. And yeah, I think it's really great that they're doing this, especially in a safe way. And so you guys don't have to worry about having to get too close to anyone. Their warehouse is humongous. And I know last time we went, it was definitely a lot of fun. And so I hope to see you guys there. Next week, we have the COVID-19 care kits, where we'll be making the same kit type event. It's like the same kit type event that we've been doing. And so these care kits will be going to the homeless in Austin, specifically through Caritas of Austin. And so there's that. And then for Dell's screening, I know we're offering points for if you volunteer to screen at Dell Seton, the medical school right off campus. We have gotten some questions about people who are asking when their points will go in. So people are still submitting their forms weekly, and what we're planning to do is near the end of the semester, like way before we finalize all the points and stuff, I'm going to go through and then give everybody all the points that they need and all the points that they got for Dell screening. So you guys don't have to worry about asking about when points will go in. They might even go in earlier, so just make sure to look out for that. But yeah, and then Makil's going to go into ongoing and resources.
And on a similar note to what Don said, Free Rice operates on a similar principle. So a lot of you guys have gone in and answered your 50 questions, which is really great. That's really cool. But it gets hard to update the live spreadsheet as we keep going. So everyone who's had their points and met the requirement, I have a separate spreadsheet keeping track of all of your points, and they will be added at a later date towards the end of the semester. So if you don't see those points in yet, you don't have to worry. Everything will be good to go. As for mask making and cheer videos, those are also still ongoing. I feel like it's pretty hard to access. So what's going to end up happening is next week, I'm pretty sure on Thursday, I will be holding a sort of info session for these 2 events, sort of giving you a rundown, what exactly you need to do, what you can do, stuff like that. So be on the lookout for that. And then those will also be ongoing, so you can submit them at any time, and the points will be updated towards the end of the semester. As for our resources recap, we have the clinical volunteering database, which is sort of in conjunction with Carissa. So we just have a bunch of different like shadowing or volunteering, hospital volunteering opportunities on there. You can look through it if you're in the Austin area. It's really helpful. And then lastly, we have our non-clinical and virtual volunteering. So there's a bunch of like sort of outside volunteering events that we have on our virtual volunteering list, which is attached to the non-clinical database, as well as the mask making, cheer videos, and Free Rice. All of those can be found with links to the non-clinical database. So if you are at home especially, this resource is really, really valuable to you. So make sure to check that out.
I'll keep this really brief, but I've had 2 makeup meetings so far, and then the makeup meeting for this meeting will be next Thursday on the 15th. So please join me if you can. They're usually pretty quick, not usually more than like 30 to 45 minutes. So come out to those if you do miss a general meeting. If you're interested in buying merch from previous years, you can look at the AMSA merch store. I just want to make it clear that if you're a paid member, you already get this general member shirt, so don't worry about that. This is for past merch. And then there are merch pickups on the calendar for the next 2 weeks, and I think I'll be adding in some more dates. So be on the lookout for those, and please do sign up if you are in Austin and you want to get your shirt. And then follow us on social media, and that's an easy way to get some easy points in as well. And then if you haven't seen already, this is the general member shirt for this year, and a lot of the officers are wearing it right now. So come out to one of the merch pickups to get yours.
Fundraisings. So coming up this next month, we have 2 committee meetings, both on Mondays. This is a time so that I could come and know some of y'all while giving me some feedback about our past events, while hopefully listening to your ideas to see what kind of events you want to see in the future. So it's a great way to hear feedback while also providing you guys an easy way to get a meeting point or a fundraising point. And additionally, in about 3 weeks, we're going to have our first online gaming tournament, which is going to be for COVID philanthropy relief, which I'll be discussing more on the next slide. And now that Charity Miles has ended, just a reminder to all who have participated, thank you once again for all the participation that we have seen. Just remember to send your progress. Just take a screenshot of the Charity Miles app of your running progress, and make sure to update your hours on the Google Sheets. And then I'll be updating your fundraising points off of that. And so once again, in 3 weeks, we'll be holding our fundraising gaming tournament. And this is going to be, all the proceeds will be donated to Altogether Austin, Texas, which is a community-based philanthropy, which will be providing resources to non-profit organizations helping those who were impacted by the COVID-19 pandemic. So on these 2 days, we would greatly appreciate any types of donations. And the point system is more elaborated on the calendar, but to just keep it short, $3 will give you 1 fundraising point, while $5 will provide you 2 fundraising points, but also an opportunity to get you to participate in our upcoming gaming tournament. So there will be 2 games, which is Scriblio and League. And just another reminder that it's open to everybody outside of AMSA. So please advertise it to your friends, your family, and we'll happily accept everyone into this tournament. And yeah.
Okay, so I am super, super excited to introduce all of you to our wonderful guest speaker for tonight's general meeting. So drum roll please into the next slide. Please everybody welcome Dr. Surve. I think he is here with us. Hi.
Yes, I'm here. Hello. Can you hear me okay?
Yes, we can.
Okay, perfect.
But yes, everyone, please give him your complete, undivided attention.
All right. How's everybody doing? Doing okay? So I am an associate professor at Texas College of Osteopathic Medicine up in the DFW area in Fort Worth. And as you can see on the slide there, I'm boarded in physical medicine and rehab, which is kind of a musculoskeletal field. As well as pain management. And I've been in Texas for about 6 years now. And so I would love to talk about kind of osteopathic medicine and the DO degree. It seems like this has become like surprisingly timely as a discussion. Just there's a lot of press right now around the president's personal physician being an osteopathic physician. Sean Conley is a DO, graduated from the Philadelphia College. And there's been a lot of, I think, misinformation out there about the osteopathic degree and just sort of what it entails. So all of this room, sort of future budding health professionals, I think it's a good discussion to have about osteopathic medicine and just make sure that we're all on the same page and answer any questions that you may have about it. Just an informal poll. So if you are, if you open up your participants tab, you can see there's like a yes and a no, and a go slower and a go faster. You all have that, yeah? So what I'm going to ask is, the question is, like, how comfortable do you feel that you could explain to somebody else the difference between the DO degree and the MD degree? And if the answer is like 100%, I absolutely know exactly what the difference is between these two and could explain it in exquisite detail, then give it a yes. If you're like, I've kind of somewhat know, but not 100%, like I know a little bit of the difference, that would be a no. If it's a like sort of, maybe, kind of, that's a go slower. And if it's I have no clue what the difference is between these two things, give it a go faster. So those 4 options that are there for you. So give it like a 4, a 3, a 2, and a 1 in terms of your confidence level of explaining these two these two degree processes. So I'm looking through the list, waiting through. So I'm seeing a lot of people kind of in the middle ground there. No judgment here, by the way. If you don't know, that's totally fine. That's why I'm here. Okay, so we're seeing kind of like in the middle. Most people are somewhere in the middle in terms of like somewhat aware, maybe not so aware. So that's fantastic, and that's good, because that's an opportunity for us to talk a little bit more about what these differences are about. And for all of you down in Austin who are pre-med folks who are interested in applying for medical school, you know that the path to become a physician is a really long and arduous one. And so typically you have to do a bachelor's degree of some kind in some major. And then after your 4 years of college, you need to apply to medical school. And this is really where the decision tree happens, right? You decide either I'm going to apply to osteopathic medical school and become a DO, or I'm going to apply to what's called allopathic medical school and become an MD, right? Those are kind of your 2 choices if you want to become a physician. Whichever one you choose, you're going to then enter into medical school, assuming you get accepted and matriculate into those schools. And then you're going to have 4 years of medical school, right? And during those 4 years, you're going to learn all kinds of things about medical problems, disease management, prescribing medications, how to do surgery. You're going to learn about delivering babies. You're going to learn about, radiology, ordering tests, making referrals, all the things that doctors learn how to do. And then at the end of those 4 years, you're going to graduate and you're going to get your respective degree, either a DO degree over here or an MD degree over here, right? But is that the end? So you get your degree and it's like, all right, now we're done. Just go into practice and everything's hunky-dory? No, absolutely not. And the reason is because after you finish your degree, then you have to go into residency, right? Residency is where you determine what kind of doctor you're going to be in the long run. And residencies run anywhere from 3 years all the way up to, so if you want to do primary care fields, family medicine, pediatrics, internal medicine, those are generally 3 years of postgraduate training, residency. If you want to be like, I don't know, a pediatric neurologic, heart surgeon, a neurologic brain surgeon or something, that could be 8, 9, or even 10 years of postgraduate training. So anywhere from 3 up to 8, even potentially more if you choose to subspecialize. So postgraduate training is anywhere from 3 to 8 years after your medical school training. That postgraduate training, whether you came from a DO degree or from an MD degree, the pool is the same, right? So you apply to the same pool of residencies. So in any given residency, there might be some DOs in that residency. There might be some MDs in that residency. You train side by side. You train in the same program, doing the same things. After your residency, you may choose to do a fellowship and subspecialize in something. Again, it's the same pool of fellowships. So you might have an MD and a DO working side by side in the same fellowship, depending on what you choose to do. So, and then after you finish your residency, now you can go and enter into practice in whatever field it is that you've done your training in. So if you've done 3 years of pediatrics, you're a pediatrician, congratulations. Now you can go somewhere, get a, and start opening up a practice as a pediatrician. And so that's regardless of whether you chose the DO track or the MD track. And so that being said, that really begs the question, like, why? So if you start up the same in college and you end up in the same place in terms of residencies and fellowships and eventually careers in some kind of field, then why are there two different tracks, and what's the difference between those two different tracks when they land in the same place? And so that's a good question. The ultimate answer to that question is really a philosophical one. It boils down to, what do you think is the role of a physician and the role and responsibility of a physician in caring for a patient? So just if you have some thoughts in the chat, toss them in. What's the physician's job? Like, what's their role and responsibility to a patient and your overall sort of job description? Okay, so take care of people, caring for people, good. So creating a relationship of trust, that's a good one. Improving health outcomes, making sure patients are healthy, good. These are all things for sure. Any other thoughts? So treating stuff, preventing, that's a good word, prevention. Helping others get better, okay. So we're getting a lot of answers, all accurate answers and good answers in terms of providing care. I would say, in the broad sense, it's the physician's job to care for people, right? If we were going to boil it down to be more specific, like in terms of like nurses care for patients too, right? Like physical therapists care for patients too. So lots of health providers care for patients. So what's special about specifically physicians that give them sort of a different skill set than others in the healthcare field? Yeah, so prescription is part of it, for sure. Anything else? Yeah, so more training, but more training to do what, right? Like why? Yeah, absolutely. Diagnosis, right? That's what we do, is diagnose and treat, right? So it's to diagnose problems and come up with a treatment plan for a patient, and then carry out that treatment plan. And so the treatment plan might involve prescribing things. It might involve doing surgery on a patient. It might involve referring them to somebody else, a counselor or a therapist or somebody else to seek help for their care. But ultimately, that's what makes the physician the top of the food chain, is the ability to make a diagnosis with the limited information, and then come up with a treatment plan for that patient, right? That's what's different about a physician versus somebody else. And so if you believe that that's the extent of your responsibility to a patient, is to diagnose them accurately, like talk to them, diagnose them accurately, and come up with a good treatment plan for your patient, then that is a very allopathic sort of view of the physician role, right? It's that you are a scientist, you're there to diagnose and treat, come up with a plan, and sort of stick to the plan, right? The osteopathic philosophy is a little bit different, we believe that the role of, kind of speaking more to some of the earlier things that were being said, the osteopathic philosophy is that no, it's the job of the physician to build a relationship with the patient and have trust and a caring relationship with this patient. And we believe that doctor-patient relationship and communication with the patient is how you provide whole person care for the patient, right? That you need to, it's not enough, patient comes in, they have a runny nose and a cough, and they have green boogers coming out of their nose, and maybe a slight fever. And any year other than this year, you would say that that person has an upper respiratory infection, and 9 times out of 10, you're right. And so you say, okay, great, you've got these signs and symptoms. Diagnosis is upper respiratory infection. Here's some antibiotics to help you with your, my treatment plan is to prescribe these antibiotics. And so here you go, take these antibiotics, drink lots of fluids. If it gets better, great. Otherwise, come back and we'll figure something out, right? An osteopathic physician would look at that same situation and have a lot of different questions for that patient in terms of, okay, you have this cold, that's great, but hey, this is the 3rd cold you've had this year. Let's talk more about that. What's your job? What do you do? What allergies do you have? Do you have pets in your house? Does somebody smoke in your house that's making you get these colds so often? Are you a caregiver? Can you take off work if I pull you out of work for things? Can I, so osteopathic physicians are really focused on understanding the entire situation around a patient, not just sort of what they're presenting with in terms of like, these are their signs and symptoms and this is their diagnosis and their treatment. So it's about building long-term relationships with patients and sort of thinking about a patient in the long-term sense. Like, I need to really understand everything about this patient, what their job is, what their hobbies are, who they're caring for, so that I can really take care of all aspects of this patient and provide care for them. And so when you go to osteopathic medical school, we put a lot of emphasis on, interpersonal communication, history taking, building rapport with patients, how to interview patients, how to, have empathy for patients, how to be a good communicator, all of those types of skills. And that is not to say that, if you go to allopathic school, you're not going to learn how to talk to patients. Of course, you're going to learn how to talk to patients. And it's not to say that if you go to osteopathic school, you're not going to learn how to diagnose and treat illness. Of course, you're going to learn how to diagnose and treat illness, right? So both degree programs, whichever one you're going to go into, you're going to learn all the things, right? The real difference between them is where the emphasis is placed. The emphasis being on communication and building relationships with patients and talking to patients, versus the emphasis being on being a good sort of like by the numbers diagnostician and coming up with good diagnosis and treatment plans. And so it shouldn't be a surprise then, when that is the focus of the 2 different trainings, that when you look at, we said whether you will go to DO or MD, you have the full spectrum of fields to choose from, right? You could become a interventional cardiologist, regardless of which degree program you chose. But when you look at, so what fields do the 2 different degrees choose, it's not surprising then that there's stark differences in terms of which fields the 2 degrees choose. So the majority of osteopathic physicians tend to go into primary care fields like family medicine, pediatrics, obstetrics and gynecology, internal medicine. And it shouldn't be surprising, given that primary care fields, those are the fields where your skill set is really important to be able to build long-term relationships with people, right? Like if you're a family physician, it's really important that you understand a patient and sort of their family and everything about that person, so that you can care for them in the long term, right? If you're a orthopedic surgeon, somebody comes in, they've fallen, they've fractured their radius, you know what I mean? And it's a displaced fracture. So you got to go in there and cut them open and put a plate on their forearm and put their bone back together so that they can heal up, you know, is it super important that the orthopedic surgeon asks you about like what pets you have at home and like, you know, just sort of all this other stuff about your personal life? Not particularly important, because you have an urgent problem that requires, you know, specific specialty care. And so the majority of allopathic physicians, MDs, choose specialty care, right? They'd go into surgical fields, internal medicine subspecialties, fields where the focus of your job is diagnosis and treatment, right? To diagnose the problem accurately, come up with a good treatment plan. And again, none of these are absolute, right? So there's, when I say majorities, I'm talking in general sense, right? So like roughly 50-ish, 55% of osteopathic physicians go into primary care, but that means that 45% don't, right? Almost half of osteopathic physicians go into specialty care and become orthopedic surgeons and oncologists and all those types of things. Similarly, 60-70% of allopathic physicians go into specialty care, but that doesn't mean all, right? So there's a good 30-40% of allopathic physicians who go into primary care and become a family physician or a pediatrician. So again, it's not that one is exclusionary in one way or another. It's just a question of emphasis, right? Where is your training emphasized, and what fields tend to come about after that? So if you have the choice, like, what do I go into? Do I go into allopathic medicine or osteopathic medicine? Again, I think it comes back to that basic question of what do you as a applicant believe is the doctor's role in providing for a patient, right? If you believe that your job is to be the best diagnostician you can be, and you know, diagnose and treat and be like a super specialist, fantastic. I'd be the first one to encourage you to apply to allopathic medical school, right? And if you're like, you know what, no, I really want to like talk to people and get to know people and learn about their families and like how disease is interrelated and how problems in one area of the body can manifest in some other area of the body, and how that all works together, then we would welcome you with open arms into osteopathic medical school. And incidentally, our admissions process in osteopathic medical schools are much more focused on those types of things. So when we are interviewing applicants, right, a lot of our questions are about, you know, just sort of, how are you in terms of communication? What kind of resilience do you have? What do you see as the role of the physician in patient care? How do you show empathy? How are you at interpersonal communication? So sort of the profile of people that we select for in osteopathic medical schools is these types of folks who are going to, you know, be the ones who are really excel at that interpersonal communication and sort of have that mindset, so that we can encourage that. And you know, if you have awesome, you know, MCAT scores, but you can't talk to people, we really are not interested, right? Because, you know, that's going to be a lot of work for us. You know, I can teach you science, but it's a lot harder to teach you how to talk to people and be a good communicator. That's a much more difficult skill to learn. So it's just, so that's kind of the fundamental difference between the two, in terms of when we talk about that philosophical difference, you know, the whole person care and like all that kind of stuff that you see, these buzzwords when it comes to osteopathic medicine. That's really what it boils down to, is a philosophical difference on the role of the patient. So I hope that you know, makes it a little more clear, hopefully, the difference between the two. So you can choose anything, you can choose any specialty you want. Like I said, I'm one of that 40% that is an osteopathic physician, but a specialist. So I'm a pain management physician in my day-to-day job. So, you know, I'm not in the majority in my field. And so, yeah, I'm one of those people who didn't choose that particular path. And so, you know, it's just, you want to have a good fit between your personal philosophy and the training that you get. It's like, if you know, there's going to be MDs who go through their training and, you know, end up being awesome communicators and really good at talking to their patients, right? So I'm not saying that that's like an impossibility. There's gonna be plenty of students who go to MD school and become great communicators and partner with patients and build long-term relationships with their patients, and that's totally fine. And there's going to be plenty of osteopathic medical students who come through and they really couldn't care less about talking to patients and, you know, become a radiologist or something and are just awesome at being a good diagnostician. You know, so there's always exceptions and there's always differences in terms of how it's going to play out for any given individual. But when you look at it in the broad sense, right, if you're looking at averages and comparing averages to each other, you know, the average osteopathic medical student is going to be much more sort of interpersonal communication focused, and your average allopathic physician is going to be much more sort of diagnosis and treatment focused in terms of in terms of how they apply their skill to patient care. So, is there any do any questions come up as we sort of make that distinction between the two fields, or just any other questions related to the practice of medicine or applications or anything else? So yeah, that's a good question. You know, I think a lot of it is just a function of time. You know, once upon a time. So I mean, part of this comes from, you know, in the 20th century. You know, the 20th century was really the move for osteopathic physicians towards full scope of practice. And so, you know, at the dawn of the 20th century, osteopathic physicians weren't that. They only learned, you know, manipulation and just sort of moving the body around. And then over the course of the 20th century, they started to expand their scope of practice into medicine and surgery and all the other sort of things that a physician does. And so as that scope expanded into unlimited practice, there was still this sort of mentality that, oh, osteopathic physicians, they're not full physicians. They don't learn all the things. They only learn, you know, manipulation and this other stuff. But, you know, from 1950 onward, you know, osteopathic physicians have largely been, you know, even. And so it's just taken time for that to wash out. When you look at physicians who are like 40 and under, there's really like nobody has a problem between the difference between the two. Most of the stigma, sort of quote unquote stigma, is really coming from the older generation, the folks who are up at top. Yeah, no, I'll go through the questions as I finish up here. Yeah, we're doing great. So as time marches on, the sort of old guard who had those ideas like, oh, the DOs are somehow less than, they're retiring and moving on, and they're being replaced by the people who are of a younger generation. And sort of the younger physicians are recognizing that there really is no difference. It's just purely a philosophical difference. So I would say, yeah, maybe social media is speeding that up a little bit, you know, just sort of in terms of raising awareness and getting people on the same page. But that's a move. That's a trend that's happening regardless of social media. It's just a function of time. So, okay, let's see. I can see why pain management would be a great fit. Yeah, absolutely. So when you look at, you know, which fields have the most DOs in them nationwide, you know, if you're going by like absolute numbers, family medicine is the number one. There are more DOs in family medicine than any other specialty. But if you look at it as a percentage, you know, of practicing physicians in the field with the highest percentage of DOs is pain management, right? Because as you're alluding to, it makes sense. Our whole philosophy is about really getting to know people and understanding the full multifaceted care, all the aspects of a patient in order to be able to provide care for them. So yeah, I agree 100%. It's a perfect fit. And the profession agrees at large because many DOs end up going into pain management. Balancing being an educator and a practicing physician, absolutely. You know, that's a personal choice, and that doesn't matter what field you go into. That's a choice that you're going to have to make in terms of your work-life balance and what your work balance is going to look like. I came from private practice. When I left residency, I was in a private practice, so I cash-based practice, seeing patients, they pay me cash, I see them. It was a pretty sweet deal. And, you know, like not dealing with insurance and all that kind of stuff. And it would seem like the perfect practice, but it was like mind-numbingly boring for me to just go in and like see your patients and then go home and then come back the next day and then see your patients and then go home and then come back the next day and see your patients. It was just like absolutely infuriating to me. I tend to thrive in like chaotic environments, and that's just something I know about myself. The fact that every week is different, like, you know, today, just to give you like today, for example, you know, I woke up this morning at 6. I had a conference, I had an admissions committee meeting at 7:30 to like talk about the incoming class and applicants and like do that whole thing. So there was a committee meeting. Then I went into the clinic. I saw patients for a few hours, had a break in my patient hours to go meet with the development people about a grant that we're applying for to do some research. Then went back to seeing patients. Then I had a lunch meeting with some students who needed some advice on applying to residency. Then I went into the classroom and taught this afternoon from 1 to 5, you know, in the lab and doing physical diagnosis and teaching the medical students. Then I drove home, stuffed some food into my face, and then jumped on this conference call. And that was like today, right? And so that is what academic life is about. It's just complete chaos, and like meetings and things just crop up, and you have to have really a lot of flexibility and be able to operate in that. Some people thrive in that environment and they become great academicians. Others like really can't. They just love like going and seeing their patients and going home and like are totally chill with that. Those are private practice people, right? Like, great, go into private practice, go do that. Don't deal with academic care. So, you know, and some people can do a little bit of both, right? They're like, I like the stability over here, but I do like a little bit of chaos. And so you can do that too. You can like have a private practice over here and maybe teach like part-time, you know, like I teach like 1 day a week at the local medical school or for the local residency. So you get a little bit of chaos, but the general day is, you know, stability, or vice versa. So it's really on you in terms of what your personality is and what makes sense to you in terms of how you're going to strike that balance for yourself, regardless of what you choose. What classes would you expect in a DO school that you would not find in MD schools? Yeah, so the only course that is really sort of purely different, osteopathic medical schools teach an additional course in osteopathic manipulative medicine, which is the sort of hands-on treatment using your hands to affect change in the musculoskeletal system. It's about a 200-hour course that's required for graduation at all osteopathic medical schools. There is no counterpart for that in allopathic medical school. Other than that, the coursework is identical. So you're going to have all the same coursework. You'll just have this additional musculoskeletal piece in your osteopathic training. That being said, you know, everybody, all DOs learn how to do manual medicine, just sort of musculoskeletal medicine in your training. But when you look at physicians in practice, the vast majority of osteopathic physicians don't use manual medicine in their day-to-day practice. Some do, and obviously, and some choose to specialize in manual medicine or osteopathic manipulative medicine. So that's an option that you can do if you're a DO. But yeah, it's not a huge number of physicians who are doing a ton of manual medicine in terms of their day-to-day practice. But you do learn it as part of your training. So that is something that is a little bit different. Are there more legal risks for osteopathic physicians? Yes and no. I think it's largely field dependent more than training dependent, like degree. It's not degree dependent, it's field dependent. So when it comes to legal risk and like malpractice insurance, it doesn't matter what your training is or what your degree is in or what your specialty is in. You're rated by the riskiest thing you do. So if I am a PM&R doc, pain management, right? There's tiers of risk. All the way, tier 1 is like OBGYN and like neurosurgery, like super high risk, right? And then it goes all the way down to tier 18. Tier 18 is like, I don't even know what falls into tier 18, but like basically no risk, right? And if you're a physician, that risk category, that tier that you fall into is not based off of what you did your residency in. It's based off the riskiest thing you do. So if I am a pain management doc, and I do joint injections, and I do manipulation, and I prescribe medicine, and I do, other procedures. That's like tier 16. So physical medicine rehab is tier 16, which is pretty darn low on the risk schedule, right? But one thing that pain management doctors are trained to do is to do spine injections. So to get the x-ray machine and x-ray people's backs and deliver medications directly to the spine for like herniated discs and things like that. And I was trained on how to do that. I did interventional in my residency, so I could certainly do spine injections if I chose to, but I don't, because that's just not where the focus of my practice is. But the second I decided I'm going to do a single spine injection on a patient, my tier level goes from tier 16 up to tier 7. Because now spine injections carry a lot more risk. You're putting needles near people's spinal cords, and if you miss, they could become paralyzed, or you could, nick something, or all kinds of catastrophic things can happen when you're messing with people's spines. And so it doesn't matter what your training is. The second you tell an insurance company, oh yeah, and I do spine injections, whether you do 500 spine injections in a year or you do 1 spine injection in a year, your tier is going to be a tier 7, right? No matter what. So when the insurance company talks to you, they don't ask like what your training is. They ask, what procedures do you do, and what procedures do you want to be able to do? And then they rate your legal culpability accordingly based off of that. So it's just depending on what you want to do as a physician. Okay, let's see. What's your day-to-day life? Okay, I think I kind of spelled that out. Just complete and utter chaos. How is the field of, I missed it. How has the field of primary care changed? And also, what are some problems? So, I mean, osteopathic physicians are physicians. So the problems that face osteopathic physicians are the problems that face all physicians. A lot of it is encroachment. So we see a lot of, nurse practitioners and physician assistants and CRNAs. And there's a lot of turf war in medicine. A lot of people trying to butt into that space. And so, we're seeing now that, nurse practitioners are gaining independent practice rights to be able to practice and prescribe on their own without supervision. And so if you go to like CVS and like a Minute Clinic or something like that, it's good. Most of those places are going to be staffed by a nurse practitioner or a physician assistant. Whereas, and so they're kind of taking over that role of primary care in many respects, not in all respects, but in many respects. And so there's a lot of just, sort of infighting that way in terms of protecting that ground. Now, the good news about that is that nationally, there's a huge primary care shortage, right? Of all the types of physicians that there are, or all types of providers that there are, there's a huge national shortage on primary care. And that's part of the reason why nurse practitioners and all these folks are getting these independent practice rights, because they're being used as a means to fill that need, right? They're like, well, all the MDs are going into specialty care. The DOs are only, 10% of the population. So even though the majority of them are going into primary care, there's still not enough of them to fill the need. All the MDs are going into super specialty fields. So who's going to fill this gap on primary care? And so that's where all the other practitioners are coming from. It's because the need is there and somebody has to fill that gap. And so that's why it's getting filled. But if you choose to be a primary care physician, there's still a wide open market for you. Like I said, it's something that just absolutely needs to get addressed one way or the other. Okay, let's see. Can you talk about research interest? Sorry, this thing is scrolling a little bit weird. Yeah, so I'm the co-director of the Texas Center for Performing Arts Health. So along with my partner, Chris Chesky, who is a professor up at UNT at the College of Music. And we research performing artists and medical problems of performing artists. So musicians, dancers, actors. We provide clinical care to performing artists, and we also research the medical problems that performing artists face. So that's where the majority of my time is spent in terms of scholarly work, is investigating the medical problems of performing artists, which is, I find, a very rewarding field. Okay, what is the state of math education in medical schools? Not sure where we're going with that. Yeah, you have to learn calculus to apply to medical school. That is true. Depends on what field you want to go into. Like if you want to do like nephrology and do dialysis on patients, that's like 100% math. I mean, like super complicated math. I could never be a nephrologist. But if you want to be you know, if you want to be a radiologist or something, you'll probably never use math, right? So it's I think a lot of it is really field dependent. For me, in my field, pain management, a lot of my math stems around like cross, so they're on one medicine and I've got to convert them over to some other medicine. So I've got to figure out the relative ratios and do the math to convert them from one drug to another. That's where my math is kind of, for me as a specialist. Does that apply to allopathic physicians as well? I'm not sure what that's in response to. I'm assuming it's something I said earlier, but I'm not sure what that would be. What implored me to pursue medicine? Yeah, I mean, I grew up in a family of physicians. I have 3 uncles who are all MDs. And, I've shadowed them and spent time with them from the time that I was like in middle school. I would hang out with them and they would talk about cool cases that they'd seen. They let me follow them around into the hospital and all that kind of stuff. So I loved medicine. I knew I wanted to go into medicine from a pretty early age, just because they were big influences in my life. But I didn't like the way they practiced medicine. They would walk into the room. This is back before like electronic health records. They would roll into the patient room like prescription pad in hand and be like, okay, what refills do you need? And they just start like writing scripts and like handing them out. And I just felt like it was a very transactional way of working with patients. They just sort of come in, what scripts do you need? Okay, here's your scripts, go. And I was just like, so like, are they going to talk to that patient? Like, are they going to find out more about them? Like, it just felt really weird about how they approached patient care. When I was just like we are right now, when I was in college, I attended a pre-med society meeting and some DO came and gave the talk that I'm giving you now about the differences between osteopathic and allopathic medicine. I didn't know the first thing. I would have been like the go faster on the questionnaire there at the time. I didn't know anything. I didn't even know osteopathic medicine existed. And they were talking about, oh yeah, we're physicians, but we have a much more, philosophy about talking to patients and building relationships. And I was like, oh my God, like this is exactly what I'm looking for, is like medicine, but you talk to people and build relationships with people. So when I applied to medical school, I only applied to osteopathic medical schools. Much to the chagrin of my uncles, they were not too pleased about that decision. But incidentally, since graduating and now going out and becoming a physician, I have 3 cousins, 2 of which are the children of those uncles who are the MDs. I have 3 younger cousins who are all now either in medical school or in residency after me, and every single one of them went to osteopathic medical school at the behest of my uncles. They were like, definitely go to osteopathic medical school. You have way more options. It's a much better choice. So they berated me when I did it like 20 years ago, but then when their own kids got through, they saw that there were more options. They were like, oh yeah, go to osteopathic medical school. That's a better choice. So they've come around full circle in terms of their thinking on that. They're like, yeah, that's a way better philosophy. So I wouldn't take their chastisement with too much seriousness. So with so much chaos, how does more to mix family pets? Yeah, of course. And so like anything else, again, it's about what you make, right? So I am very diligent about my time, that when I'm with my family, I'm with my family, and like I turn my phone off and I don't answer emails and I don't answer texts. If it's something is super urgent, they know that they can, text me with like a 911 and then I'll actually answer it. But otherwise, people just understand that if they're texting me something after hours, I'm not going to respond to it until the following morning. And so that's just the professional boundaries you have to set for yourself. Nobody's going to set that for you. When you're a physician, it's just an unlimited press for your time. Everyone wants a piece of your time for whatever reason. And so the only way to push back is for you to make a concerted effort to push back. And that's true of whatever field you go into. MD, DO, specialist, primary care, doesn't matter, right? Your boundaries are what you set. So I have very, very strict boundaries in terms of protecting my personal time with my family. But that's about it. That's my own personal choice. What hobbies do I have in my free time? Yeah, I am a very amateur musician. I've been involved in music since I was a little kid. And so that's obviously something that made sense to move into performing arts medicine as a field because of that background. So so that's my personal hobby. Yeah, definitely not your dad. I no comment on that. No comment whatsoever on that statement. Okay, great. So I think that is the end of the questions there. Does anybody else have any other questions? I know we're kind of over time, so I don't want to be too disrespectful of your time. But I would love to hear, if you have any other final questions or anything else.
If I can interject, Dr. Surve, we really appreciate your time, and I think I would be happy to stay after. I just want to add on that if anyone has to go, it is a school night, so we don't want to keep you here too late. But yeah, you guys are free to go if you need to. Although if Dr. Surve has any closing statements, or if we end up getting more questions, do feel free to post in the chat, and Dr. Surve can obviously leave as soon as he has to go. But we just appreciate all of y'all being here on another general meeting. We'll see y'all again at any upcoming events. Thanks.